Hi there, my valued and highly treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I'm a clinical pharmacist by profession and by training, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building amongst the healthcare sector workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your precious time as I share a few tips that you may find useful in your line of duty. So our first question reads, HPB, a 48-year-old male, presents to the cardiac clinic at your hospital. He has a past medical history of gout and hypertension. The readings or the vitals at the clinic today include a BP of 156 systolic and 87 diastolic, and that has been so for the past 2 consecutive months. He currently takes nifedipine XL 90 milligrams once daily orally and 300 milligrams of allopurinol once a day. Lifestyle modifications don't seem to be working for this gentleman. He declares he is unlikely to modify his behavior further. He doesn't want to make any further adjustments. So my question to you is, which of the modifications in his antihypertensive medications listed below would confer his greatest benefit? Would it be the addition of diltiazem 240 milligrams orally once daily, or would it be the addition of 50 milligrams of chlorothalidone taken orally once daily after breakfast, or would it be the inclusion of 200 milligrams of metoprolol succinate taken orally once daily, or would you settle for 2.5 milligrams of ramipril administered orally once daily? I'll give you 10 seconds to make the appropriate choice. So in my opinion, D would be the correct answer. I would add 2.5 milligrams of ramipril to his current regimen. I would like to make a few comments, such as generally a thiazide diuretic like chlorothalidone, which is our option B, or hydrochlorothiazide, or even metolazone would be added, but this patient suffers from gout, remember, and makes this potentially problematic. Now we know that thiazide diuretics will compete with uric acid elimination at the kidney level. That would cause gout exacerbation. So I would not opt for B, chlorothalidone, or any other diuretic at all. Now, while diltiazem and metoprolol succinate may be reasonable choices, the doses quoted there, that is 200 and 240 milligrams respectively, aren't considered appropriate starting doses. They would be too high, and they would likely cause bradycardia and or hypotension, in my opinion, in this particular patient, that would worsen his condition. Now we know that metoprolol succinate is normally initiated at doses of 25 to 100, not as high as 200 in option C. So that makes option C wrong. We usually start at 25 to 100 orally once a day, and that can be titrated at weekly intervals to a maximum dose of 200 orally once daily if you are treating a heart failure patient, and you can go up to 400 milligrams daily if you're managing hypertension for patients, and assuming that they can tolerate such high doses. Now, ramipril, the ACE inhibitor, which is also called altase, at a low dose is a reasonable choice in this particular patient, and we can titrate. We don't have to leave it at 2.5 orally once daily. You can titrate upwards to a maximum of 20 milligrams according to many guidelines out there. Yeah, so we can titrate gradually from 2.5 to a maximum of 20 orally once daily. It is the least likely to cause major problems with gout in this particular patient. And it's important to note that ACE inhibitors can also increase uric acid levels, but they are not as drastic as the thiazide diuretics. At this point, it is important that shared decision making with the patient be made about the various pros and cons of treatments for the treatment or the therapy to be sustainable. Let's move to the next slide, please. WOC, a 52-year-old Kenyan man, received a drug-eluting stent at the Aga Khan University Hospital, Parklands, Nairobi, via PCI to the left anterior descending artery, what we abbreviate as LAD. He is prescribed aspirin and clopidogrel as a DAPT, what we call dual antiplatelet therapy. Now, WOC asks, why does a drug-eluting stent require DAPT? Because he's paying for his medications and he finds the duration may prove unsustainable off pocket. So my question to you is, which of the responses below would be the most appropriate for this gentleman who wonders why you have to keep him on 2 sets of medication for too long? So would it be they work to prevent stent thrombosis of the coronary artery, or is it true that they work to inhibit restenosis of the coronary artery, or is it true that they work to decrease the patient's chances of having a stroke, or is it true that they help reduce the risk of heart failure? I'll give you 10 seconds to choose the correct option from that list of 4. In my opinion, A is the correct answer. They work to prevent stent thrombosis of the coronary artery. Now, antiplatelet drug therapy helps prevent stent thrombosis, which can occur in a relatively short time frame after PCI. And that is why DAPT is recommended for at least 12 months in patients receiving a drug-eluting stent. Now, the drug-eluting stent itself inhibits restenosis more than a bare metal stent does. And I would just like to add that the antiplatelet medications such as aspirin, clopidogrel, prasugrel, and ticagrelor don't reduce heart failure at all. So that makes option D wrong. They will reduce the primary and secondary stroke in patients. However, the decrease in stroke isn't the reason why DAPT is given to patients with the DES, the drug-eluting stents. So that also makes C wrong. So I would like us to move to the next slide. As the cardiology clinical pharmacist at your hospital, you have been tasked by the clinical team to develop a pharmacologic plan which includes dyslipidemia therapy for a patient on polypharmacy with a very high potential for multiple drug-drug interactions due to the CYP450 substrates. My question to you is, which of the statins listed below would be the least likely to exhibit CYP450 drug-drug interactions? Would it be Lovastatin, Atorvastatin, Pravastatin, or Simvastatin? I'll give you 10 seconds to choose the correct answer. Atorvastatin it would be. Of the 4 statins listed above, Atorvastatin, which is also marketed as Pravachol, is the only one which isn't metabolized via the CYP450 system. It is, however, known to interact with other medications via other pathways, e.g. cell membrane influx and efflux transporters. Now, lovastatin, which is marketed as Mevacol, and simvastatin, which is also called Zocor, are major substrates of the CYP453A4 enzyme, while atorvastatin is a moderate substrate of the CYP3A4 enzyme. They are more likely to be associated with drug-drug interactions when co-administered with other medications that influence the CYP450 enzyme system. So be cautious when using lovastatin, atorvastatin, and simvastatin in any form of polypharmacy, which is very highly likely in patients with cardiovascular diseases. Let's move to the next slide, please. The next question reads, in which of the following patient scenarios would dabigatran use be most appropriate when attempting to determine if a patient with atrial fibrillation with a CHA2 score of 5 should be initiated on dabigatran or warfarin for the prevention of a VTE? Would it be a patient with a feeding tube, require opening the capsule during administration, require open capsule administration, or would it be patients with a prosthetic heart valve, or patient with an estimated creatinine clearance of 35 ml per minute, or patient with a history of MI? I'll give you 10 seconds to choose the correct answer. So C it is. Patients with creatinine clearances below 30 were excluded from the RELY trial and thus haven't been adequately studied. Now, about 80% of dabigatran is excreted in urine, and it's highly dependent on renal elimination, likely through PG. Now, dabigatran is indicated for non-valvular atrial fibrillation, not prosthetic heart valves. It is also approved for use in DVT and PE preventions and treatments, just for your information. And feeding tube wouldn't limit the ability to administer warfarin. But on the other hand, dabigatran shouldn't be broken or chewed, neither should the capsules be opened, as this can lead to a 75% reduction in absorption. Now, that is from the literature insert, so I would advise you to read it further. They recommend the capsules be swallowed whole. Do not tamper with them. Now, the RELY trial demonstrated a significant increase in MI with patients taking dabigatran compared to warfarin, which makes answer D wrong. Now, just like to emphasize that dabigatran isn't approved by the FDA for use in prevention of MI. So all those facts make C our correct answer. Let's move to the next question, please. FKT, a 35-year-old male patient, undergoes SVT treatment, supraventricular tachycardia treatment with adenosine. The cardiac team at your hospital has already administered 1 dose of 6 milligrams IV without noticing any change on his ECG or EKG. His vitals include a heart rate of 220 beats per minute, pretty high, and SVT is confirmed by the ECG or EKG. He has a systolic blood pressure of 140, diastolic of 80, with a respiratory rate of 22, and he isn't desaturating. He is saturating well, That's at 100% on room air. He has a body temperature of 98.4 degrees Fahrenheit. So my question to you is, what would be the next course of action in FKT's management? Would you consider direct current cardioversion? Would you administer nicardipine at a dose of 5 milligrams IV push? Or would you administer 100 milligrams of lidocaine IV push? Or would you administer 12 milligrams of adenosine IV push? I'll give you 10 seconds to choose the correct answer. So in my opinion, D would be the correct answer. I would consider doubling the dose and administering via IV push. For the treatment of SVT, the initial dose of adenosine is 6 milligrams IV. Now, if there is no clinical response, in your opinion, additional doses may be administered, but the dose should be increased. Don't keep it at 6, increase it to 12 milligrams, and you may administer, according to guidelines and many hospitals, 2 additional doses of 12 milligrams IV push. Now, cardioversion may be appropriate in situations where appropriate pharmacologic cardioversion have failed, or the patient is hemodynamically unstable, or the patient demonstrates signs and symptoms of hypoperfusion. Now, lidocaine isn't an effective agent for supraventricular tachycardia. And the other one, B, nicardipine has little effect on the heart rate or rhythm. So that makes options A, B, and C inappropriate or incorrect. Now, adenosine works by activation of inward rectifier potassium currents and inhibition of calcium current, and this causes hyperpolarization and disruption of the calcium dependent action potentials, which predominantly is found in nodal tissues, that is the AV and SA nodes, but it's to a lesser extent in the case of SA. Now, the goal of adenosine administration is often diagnostic rather than therapeutic. Although it may convert the SVT to a normal sinus rhythm, it is primarily used to identify the underlying rhythm that may not be distinguishable on an ECG. That is just a by the way. Let's move to the next slide, please. The question reads, JWW, a 36-year-old white woman with a history of heterozygous familial hypercholesterolemia, what we abbreviate as HEFH. She has been compliant with the taking of medications. She takes a maximum dose of rosuvastatin. She's already on ezetimibe as well. Now, her LDL cholesterol remains elevated at 135, and she wants to do whatever is possible to further lower her LDL cholesterol and, by extension, the risk for cardiovascular disease. And the family history: the father had the same condition and died at a very young age of 38 years. So my question to you is, which of the drugs listed below should be the add-on choice given this lady's history? Would it be colesevelam? Would it be simvastatin? Would it be alirocumab or gemfibrozil? I'll give you 10 seconds to choose the correct answer. In my opinion, C would be the correct answer. Now, alirocumab, which is also marketed as Praluent, is a PCSK9 inhibitor antibody which is administered every 14 days subcutaneously. It is recommended in patients with heterozygous familial hyperlipidemia, the HeFH, who are already on maximum therapy, that is a statin plus ezetimibe. Now, Simvastatin is a statin or an HMG coenzyme A reductase inhibitor that is taken once daily orally. Switching to this statin would reduce the efficacy of the LDL lowering and would clearly be a wrong option. Now, adding this to the existing regimen would expose the patient to dual statins, which is not recommended in therapy. Remember, our patient is already on rosuvastatin, if I remember well. So it would not be appropriate to add sugar to honey. It would not add much value. Therapeutically, it would be wrong. Now, colesevelam, which is also marketed as Welchol, is a bile acid sequestrant which primarily lowers TC and LDL cholesterol, but it can increase triglycerides and must be taken daily with each meal. Gemfibrozil, which is marketed as Lopid, is a fibrate and mainly used for lowering TG, which isn't our patient's problem at all. So patients with HeFH have LDL receptors that don't work as well at the liver, extracting LDL cholesterol from the blood, and as a result of this, they need treatments that can facilitate further extraction of this cholesterol. Now, the PCSK9 inhibitors are known to aid in this effort, so they will be the most appropriate addition to this patient who is not doing well on rosuvastatin plus ezetimibe. Let's move to the next question, please. Of the interventions listed below should be considered and or implemented prior to the administration of a vasopressor for management of hypotension? Would it be ensure all patients are receiving supplemented oxygen? Would it be elevate the arm receiving the vasopressor? Or would it be ensure the patient has received adequate IV fluids? Or would it be compression stockings that extend from the feet to the upper thigh? I'll give you 10 seconds to choose the correct answer. For answer C, and ensure that the patient has received adequate IV fluids. Now, patients should have adequate volume setters prior to utilization of vasopressors. Having an adequate amount of vascular volume will ensure appropriate increases in blood pressure more effectively and will also maintain the perfusion of the vital or key organs. Now, the most common way to provide adequate amounts of volume is to administer IV fluids such as normal saline prior to starting any vasopressors, and this may not be needed in case the patient has, for example, heart failure. Therefore, we need to restrict the volume, or the patient already has fluid overload. Now, sometimes giving a hypotensive patient IV fluids alone can raise the BP sufficiently. So if you can achieve that goal without starting vasopressors, that would be the most ideal in most cases. But volume fluid resuscitation is very key in this category of patients. Let's move to the next question, please. ZBJ, a 54-year-old male presents to the clinic with a past medical history of hypertension, obesity. He has a BMI of 43, pretty high. He also suffers from gout and osteoarthritis. His current meds include 40 milligrams of lisinopril taken once daily orally, 300 milligrams of allopurinol taken orally once a day, and he also takes paracetamol tablets, 1 to 2 tablets of the 500 milligram when in pain, up to 4 times daily. And selected vitals include a systolic blood pressure of 147, diastolic 93, with a heart rate of 60. Now when you repeat these readings after giving him a brief rest, the systolic falls slightly to 145, the diastolic rises by 1 to 94, and the heart rate rises slightly by 2 to 62. The lab values are within normal limits. So my question to you is, which of the adjustments suggested below would be the most appropriate for his antihypertensive therapy? Would you consider initiating 12.5 milligrams of hydrochlorothiazide once daily after breakfast orally? Or would you consider initiating 25 milligrams of metoprolol twice daily orally? Or would you consider initiating amlodipine at a dose of 5 milligrams once daily orally? Or would you initiate the extended release version of verapamil at a dose of 180 milligrams once daily? I'll give you 10 seconds to choose the correct answer. For C, I would add amlodipine 5 milligrams orally once daily. Now, ZBJ's current antihypertensive regimen of therapeutically maximum doses of lisinopril isn't adequately controlling his blood pressure. Now, the use of metoprolol and verapamil in the setting of low normal heart rate would be inappropriate, as this may increase chances of bradycardia. Remember, his heart rate is around the 60s, and we don't want to go to a level where the pulse will fall below 60. And then the use of hydrochlorothiazide, a thiazide diuretic, in the setting of gout wouldn't be the best of the listed options. It would exacerbate this gentleman's gout. So let's move to the next slide, please. ASL, a 69-year-old Ugandan female residing in the city of Nairobi, Kenya, presents to the cardiac clinic at the Aga Khan University Hospital with a past medical history of coronary artery disease. She had an anterolateral myocardial infarction 6 months ago. There was stent placing, 2 stents to be specific, and she also suffers from dyslipidemia, and she is hypertensive. Now, her recent 2D echo showed a left ventricular ejection fraction of between 35 and 40%, and she denies shortness of breath, dyspnea on exertion, reduced exercise tolerance, orthopnea, or paroxysmal nocturnal dyspnea. Her physical exams are unremarkable. Your cardiologist on duty gives a diagnosis of systolic heart failure. So my question to you is, how would you stage ASL's heart failure? Would you consider her to be in stage D, C, B, or A? I'll give you 10 seconds to choose the correct stage. I would settle for answer C. Now, basing on the ACCF stroke AHA heart failure guidelines, this lady is considered stage be heart failure, given that she has noted structural heart disease via the 2D echo that was done, but she hasn't experienced heart failure symptoms in the past. All the other stages are wrong, in my opinion. Let's move to the next question, please. ALK, a 54-year-old male patient, presents to the accident and emergency with palpitations. This patient has a past medical history of carotid artery stenosis, and he also happens to be hypertensive. He is currently on lisinopril 10 milligrams orally once daily, co-formulated aspirin and dipyridamole, which he takes twice daily for stroke prevention. Upon evaluation, he is found to have an SVT, supraventricular tachycardia, and he is hemodynamically stable. So my question to you is, which of the following is the most appropriate for ALK at this moment? Would you consider administering an IV push of 12 milligrams of adenosine, or 3 milligrams of adenosine, or 6 milligrams of adenosine, or would you go for a higher dose of 18 milligrams of adenosine? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for 3 milligrams IV push. Now, dipyridamole increases the cardiovascular effects of adenosine, including asystole, via inhibition of the uptake of adenosine in cells. An initial dose of 3 milligrams of adenosine is recommended instead of 6 for patients that are receiving dipyridamole concurrently. Now, if dipyridamole was not present in this regimen, then we'd go for 6 milligrams, just as a by the way. Now, conversely, theophylline and to a smaller extent caffeine may diminish the effects of adenosine. Now, prior to the administration of adenosine for SVT, ensure that the patient is connected to a defibrillator. Now, continuous cardiac monitoring and oxygen saturation are necessary when intervening in this kind of cases. Let's move to the next slide, please. The question reads, GEW, a 63-year-old white female, presents or reports to the cardiac clinic at your hospital for routine follow-up. Past medical history includes type 2 diabetes mellitus, dyslipidemia, hypothyroidism. She has no complaints during this appointment and claims to be fully compliant with her current regimen. She is currently taking 10 milligrams of glipizide once daily for her diabetes, alongside 1,000 milligrams of metformin, which she takes after breakfast and dinner. She also administered a bolus insulin of insulin detamir, 15 units subcutaneously in the morning, and also takes levothyroxine at a dose of 100 micrograms once daily. And in addition to that, she takes 20 milligrams of Atorvastatin at bedtime. Now, selected fasting labs include a glucose of 182, serum creatinine of 1.1, AST of 18, ALT of 24, A1C of 8.8%, total cholesterol of 183, HDL of 48, and you are told the LDL is, they were not able to calculate it, but the TG was 468 and the LDL was 48. The TSH was 2.3. Now, based on this information provided, what would be the next best course of action in the management of Lady GEW? Would you increase her levothyroxine dose to 125 micrograms orally once a day after breakfast? Or would you increase the dose of Atorvastatin to the lower end of the high intensity statin therapy of 40 milligrams at bedtime? Or would you intensify the type 2 diabetes mellitus therapy? Or would you add cholestyramine at a dose of 4 grams orally twice daily? I'll give you 10 seconds to choose the correct answer. So I would personally consider intensifying the type 2 diabetes mellitus therapy. Now, this patient's type 2 diabetes mellitus, in my opinion, is poorly controlled with an A1C of 8.8%, which may possibly be contributing to high elevated TG levels. Now, many practitioners continue intensifying dyslipidemia therapy, usually with statins, in an attempt to lower the TG, but that may not be the best course of action. Unfortunately, what results is a very low LDL but minimal change in TG because of the potential contributing issue of poor glycemic control has not been addressed just by increasing focusing on the lipid therapy. Now, in my opinion, the correct option would be to intensify the DM therapy, with a goal of improving the overall glycemic control. Now, when I look at option D, adding cholestyramine, in my opinion, would be incorrect because bile sequestrants can increase TG, and they need to be given at separate times away from other oral medications since they bind anything in their way. So when they are co-administered with other oral medications, you may end up with subtherapeutic levels, so they wouldn't be the best option in my opinion. We would end up with poor absorption of all other oral medications, and this would grossly even affect the absorption levothyroxine if concurrently administered. Now, in my opinion, answer A is wrong because levothyroxine dose does not need to be increased. From the TSH we are given above, I consider that value normal, so I wouldn't tamper with the levothyroxine dose at all. So let's move to the next slide, please. Question reads, which of the advantages listed below corresponds to the use of rhythm control strategy to manage an atrial fibrillation patient? Would it be rhythm control may improve a patient's cardiac output and heart failure symptoms more than rate control? Or is it B, rhythm control will require less patient monitoring for drug toxicities than rate control? Or is it C, rhythm control will significantly decrease mortality when compared to rate control? Or is it D, rhythm control will significantly decrease the rate of stroke when compared to rate control? I'll give you 10 seconds to ponder over those 4 options and choose the correct answer. I would settle for answer A. Now, rhythm control improves the efficacy of the heart's ability to contract and therefore move blood round about the body. Rhythm control has more potential side effects than rate control and will require at least as much monitoring as rate control. Now, the monitoring for rhythm and rate control is different. Current data demonstrates no difference in all case mortality. Then I would just like to emphasize that rhythm control in atrial fibrillation still requires anticoagulation to prevent stroke, while rhythm control has the ability to confer improvement in cardiac function. Their use should be weighed against the side effects and complications related to antiarrhythmic drugs being used. Now, all those many words would make me biased towards selecting option A. Let's move to the next slide. A patient with refractory angina is currently taking carvedilol, lisinopril, isosorbide dinitrate, and aspirin as prescribed. Is compliant or adherent to the regimen. After being interviewed, he is graded as Canadian Cardiovascular Society Class 4. So my question to you is, which of the comments listed below, emerging from the interview, is most consistent with the CCS Class 4 classification of a patient? Is it A, I only have chest pain if I walk up several flights of stairs or walk up a steep hill? Or is it B, I have a lot of chest pain throughout the day even when I am sitting down watching television? Or is it C, I don't have chest pain if I take it easy, but I will get chest pain if I clean the house or walk 1/2 a block to my friend's house? In other words, if he indulges in light activity. Or is it D, I rarely have chest pain. The last time I had chest pain, I was helping my son build a fence in his backyard. So I'll give you 10 seconds to choose the correct answer. I would settle for answer B. Now, a CCS Class 4 patient is severely limited in the amount of ordinary class activity they can perform, with the major difference between Class 3 and 4 being the fact that angina at rest occurs in the Class 4, which occurs in Class 4. Therefore, the patient experiencing chest pain while watching TV, which is at rest, belongs to Class 4. I would like just to emphasize that Class 1, this kind of classification, encompasses those patients in whom ordinary physical activity doesn't cause angina, that is, while walking or climbing stairs. And in them, angina occurs with strenuous, rapid, or prolonged exertion at work or when recreating. Now for Class 2, slight limitation or ordinary activity, there is slight limitation. Angina occurs when they are walking or climbing stairs rapidly, not at a normal pace, when they are walking uphill, when they are walking or stair climbing after meals, when it's cold or when it's windy, or when they are under emotional stress, or only during a few hours after awakening. Now, walking more than 2 blocks on the level or climbing more than 1 flight of stairs at a normal pace and in normal conditions can also cause chest pain in them. Now for the Class 3, there is marked limitation of ordinary physical activity, and angina occurs when they are walking 1 to 2 blocks on the level or climbing 1 flight of stairs in normal conditions at a normal pace. Now for the Class 4, there is inability to carry out any physical activity without discomfort, and the angina symptoms may be present at rest. So that's just for your information. Let's move to the next slide. So the next question reads, AMM, a 50-year-old male patient, has been taking clopidogrel and aspirin for a paclitaxel DES, which was placed in his circumflex artery 10 months ago when he had an NSTEMI. He contacts you for medical advice and inquires when he can discontinue clopidogrel and undergo a total knee replacement surgery, an elective surgery. My question to you is, which of the answers below would be the best advice to Mr. AMM? Would you advise him to continue the clopidogrel for surgery as there is minimal bleeding risk? Or would you advise him to discontinue clopidogrel today and ensure a minimum of 5 days prior to surgery? Or would you discourage him from discontinuing clopidogrel for at least 60 more days? Or would you advise him to avoid taking clopidogrel and aspirin for 10 days prior to his surgery? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for answer C. Now, dual antiplatelet therapy should be continued for at least 12 months in NSTEMI patients receiving a drug-eluting stent. Remember, our patient is already at the 10-month mark, and since this is an elective surgery, I would advise him to clear the remaining 2 months. Now, clopidogrel is a prodrug that, when activated by phase 1 metabolism, results in irreversible inhibition of the P2Y12 component within the ADP receptors of the platelets. Now, the elective knee surgery that this patient plans should be postponed since it is not urgent or emergent. I would advise him to clear his full year of DAPT before considering surgery. So that, in my opinion, makes the other 3 options wrong and option C correct. Let's move to the next question, please. Which of the angiotensin receptor blockers, the ARBs, listed below isn't indicated for pediatric hypertension management? Is it olmesartan, losartan, telmisartan, or valsartan? I'll give you 10 seconds to choose the correct answer. So when you read available literature, olmesartan, valsartan, and losartan have indications for use in the management of hypertension in the pediatric population. Now, telmisartan, on the other hand, does not have an indication for use in the pediatric population. So that makes alternative C wrong. Let's move to the next slide, please. It reads, HKL, a 55-year-old patient, is being considered for antihypertensive therapy at your cardiac clinic. Currently, he takes Simvastatin at a dose of 40 milligrams at bedtime. So my question to you is, which of the antihypertensives listed below has drug-drug interactions with HKL's Simvastatin therapy? Is it atenolol, amlodipine, hydrochlorothiazide, or fosinopril? I'll give you 10 seconds to choose the correct answer. So amlodipine it is. Now, due to the CYP3A4 metabolism, concomitant use of simvastatin and amlodipine isn't recommended. With simvastatin doses exceeding the 20 milligram daily mark, that is to avoid potential adverse drug reactions associated with elevated serum levels of simvastatin, which can cause, for example, myopathy or rhabdomyolysis. I would discourage co-administering amlodipine with simvastatin. And if you have no options, then you have to use very low simvastatin doses, but I would recommend we do not co-administer the two because of that major drug-drug interaction. Let's move to the next slide, please. The question is, your cardiologist is considering prescribing ranolazine for refractory angina in a patient. My question to you is, which of the counseling points listed below would be the most appropriate for this patient? Would you tell the patient it's okay to drink grapefruit juice with ranolazine without concerns? Or do you tell the patient to take ranolazine on an empty stomach for optimal absorption? Or would you tell the patient ranolazine should be swallowed whole and not crushed, broken, or chewed? Or would you tell the patient if you miss a dose, it's okay to double the next dose to make up for the missed doses? So I'll give you 10 seconds to choose the correct answer. So I would settle for answer or option C. Now, ranolazine is supplied as an extended release tablet that should be swallowed whole and not crushed, broken, or chewed. It can be taken without regard to meals because it's metabolized by the CYP3A system. The patient should limit grapefruit juice intake due to a major drug-food interaction that would occur if you opted to sip grapefruit juice while on ranolazine. Now, if the dose is missed, I would just recommend skipping that dose and taking the usual dose at the next scheduled time. It's not necessary to double doses to compensate for any missed ones. So I'll settle for option C to avoid affecting the pharmacokinetics of this drug. Let's move to the next slide, please. A 28-year-old Hispanic female presents to your hospital with a past medical history of hypertension, obesity, and allergic rhinitis. And you establish that she is 22 weeks pregnant. She currently takes lisinopril, an oversight there, diphenhydramine, multivitamins. You recognize that she shouldn't be taking lisinopril while she is pregnant, and you want to convert her to a safer alternative. My question to you is, which of the antihypertensives listed below would be the most appropriate for this expectant patient? Would you settle for aliskiren, Labetalol, hydrochlorothiazide, or olmesartan? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for Labetalol. Now, ACE inhibitors such as lisinopril and ARBs such as olmesartan and aliskiren, which is a direct renin inhibitor, are all RAS agents, renin-angiotensin-aldosterone system agents, and they have a pregnancy category D listing, especially during the last 2 semesters, and they should be avoided in pregnancy in general. Now, while thiazide diuretics are technically classified as category B, their use in clinical practice is limited and not recommended. Is a potential for them to reduce the needed physiologic increases in plasma volume during pregnancy, and they may also increase electrolyte imbalance, because such ladies tend to have an increased risk of nausea and vomiting compared to other ladies. And having a diuretic would only worsen the situation and exacerbate gestational diabetes, which can be very common. Remember, thiazides can also lead to hyperglycemia in some cases. They can cause exacerbation of gestational diabetes through that mechanism. And yeah, there have been case reports of thrombocytopenia in neonates born to mothers who at some point took thiazide diuretics. So I would discourage pregnant ladies from taking drugs such as hydrochlorothiazide. And then Labetalol, being a mixed beta blocker, and one other drug called guanfacine, which is an alpha-2 receptor agonist, are preferred options during pregnancy. They are safe. Now, methyl dopa has been considered a drug of choice in the past in pregnancy, but with the emergence of drugs, safer drugs such as Labetalol, the use of methyl dopa is declining due to a small risk of hemolytic anemia that has been reported on some occasions. So I would settle for Labetalol. Let's move to the next slide. Question reads, a male patient classified stage C heart failure presents to the cardiac clinic with worsening symptoms, e.g. marked decrease in exercise tolerance, shortness of breath with everyday activities such as brushing of his teeth and taking a shower. He needs to add 2 pillows behind him in bed to sleep comfortably. And he denies chest pain or shortness of breath while at rest. Now, on physical examination, the cardiologist notes rales in both lung bases and a 1+ lower extremity edema bilaterally. So my question to you is, how would you classify this patient according to the New York Heart Association functional classification? Is he in class 4, class 1, class 3, or class 2? I'll give you 10 seconds to choose the correct class. So class 3 it is. Now, what backs that is that he has marked limitations on physical activity and shortness of breath in activities of daily living. Now, because this patient doesn't have shortness of breath or mention any inability to carry on out physical activities, wouldn't classify the patient class 4. Now, because the patient has more severe limitations to physical activity and ordinary activities cause shortness of breath, he cannot be in class 2 either. So my highly esteemed and treasured viewers and listeners, that brings us to the end of part 31 of our pharmacotherapy MCQ series. I appreciate the fact that you sacrificed and made time to listen to me and to watch the video. Now, if this video helped you in any way, I would like to urge you to remember to give it a thumbs up and to like it and to share it widely. And if you haven't yet done so, I would like to request you to subscribe to my YouTube channel, and I would like to promise you that the best is yet to come. I would like to thank you for viewing and for listening, and I look forward to interacting with you further in part 32 of our series. Thank you for always being there for me.